Good morning. I welcome you all for the CCP specialty update in geriatric medicine in collaboration with the Sri Lanka Association of Geriatric Medicine. And today, the theme is the cognitive problems in older adults. We are having four eminent speakers with four different topics. Without any delay, I would like to invite the first speaker. She is Dr. Lasantha Ganewatta. She's a consultant physician at the New District General Hospital, Matara, and she will be talking to us on assessment of cognition. Over to Lasantha.
Thank you, Shamita. Thank you very much for your kind words of introduction. Let me share my screen. Good morning, everybody. So today the topic is cognitive assessment in older adults. I would like to thank Ceylon College of Physicians as well as Sri Lankan Association of Geriatric Medicine for giving me this opportunity to do this presentation. As you all know, the cognitive assessment is paramount important in older adults, especially when there is a concern of their cognition. So, we all know Sri Lanka has one of the fastest aging population in Southeast Asia. Currently, our population, 13 to 14% of our population is aged more than 60. So by 2050, 1/4 of us will be more than 60. So therefore, as physicians who are looking after, as doctors who are looking after this wide cohort of geriatric population, it's important to know their main geriatric problems, as well as how to do at least a brief assessment of them. We all know that cognitive impairment is one of the geriatric giants that we encounter when we see geriatric patients, people who are more than age 60 to 65 years. So therefore, I feel today's lecture will be important for the audience when they do their practice, especially when they are in the outpatient clinic, when they are in the ward, when they are in a rush emergency department, to do how they can manage their time and do a cognitive assessment of these elderly patients. So during next 20 to 25 minutes, my outline of my lecture is like this: introduction, use of cognitive assessment, and tools used to test cognitive impairment, distinguishing causes of cognitive impairment, and qualitative assessment, little briefing about the qualitative assessment, and integrated care for older people, ICOP, which is introduced from WHO regional office, and we were trained as master trainers to train primary care physicians to identify the geriatric problems, especially this cognitive impairment, and conclusions. So we all know that cognitive assessment is useful to test for cognitive impairment. Main three areas we concern is the deficiency of their knowledge, thought process, and judgment. So we concentrate these three areas when we do a coherent cognitive assessment. So aging and cognition will have very close relationship. We all know that. Three wide categories of cognition is there. Three wide categories are there in their cognition. First and foremost is the physiological aging and physiological changes in their cognition. This cognitive aging does not fit into any of the categories of cognitive impairment or dementia. But remember that we need to deal with this problem when our patient cohort is getting wider. And second thing is the cognitive impairment, not dementia. If the people do have cognitive impairment, but we are not able to categorize them as dementia because they are not compatible to the scores and cutoff values of our tools. And third category is the dementia. You will understand the burden of dementia when the population is aging, when we are aging. At the age of when it comes to the 65 years of age, so it is less than 1% the prevalence of dementia, but more than 65, it goes to nearly 11%. When aging advances, when it is more than 85 years of age, 1/3 of them will have dementia. So you can understand the importance of the assessment and diagnosis of dementia when we need to make a shared care plan for their further management when the age advances. And cognitive impairment, not dementia, will carry 17% of prevalence when people age more than 65 years of age. So the use of cognitive assessment, that also we need to understand. So we do screening for cognitive impairment, especially we do not do cognitive assessment of each and every patient because it is time consuming, it is costly, as well as it needs specialized manpower. So then the screening, we do cognitive impairment when there is when they raise a concern, either patient or the caregiver or the relative, when they raise a concern that this patient, this patient does have some sort of cognitive problem, then we do screening. Then we assess, when we do a cognitive assessment to differentiate the diagnosis of course. Once we diagnose dementia, we need at some point we have to differentiate which diagnostic category this dementia fit into, like Lewy dementia or the frontotemporal dementia. It is a little advanced. Then the third category is rating the severity of disorder or monitoring the disease progression. That is when we do the review, either in the clinic or in the ward, when we do reviews after diagnosing, then we do cognitive assessment. These are the three areas where clinicians do their cognitive assessment. As I said earlier, this is time consuming and it is costly. So therefore, we need to understand what is the importance of cognitive impairment, what is the why we do this cognitive assessment, the purpose and the time which is available to assess this patient. So time, the purpose of the cognitive assessment both carry a important task, important thing. So then only we select which instrument, which tool we use to assess the cognition. These are the commonly we use even in our country and when we were doing our overseas training. So these are the main cognitive screening tools we use. Mini-mental state examination from medical school days, we are familiar to that MMSC, and the Montreal cognitive assessment. It is advanced than MMSC, which Montreal cognitive or the MOCA assesses many categories, many components of the cognition compared to MMSC. So then the abbreviated mental test, AMT is the one is rather simple test which we use in acute medical take to assess the delirium, acute confusional status of elderly people who does have fluctuating course of their confusion. So then clock drawing test. Clock drawing test is also widely used cognitive screening tool where we give the task of drawing a clock to the patient. And then the mini-COG, that is an extended version of clock drawing test where we assess orientation in addition to the clock drawing test. Then there is some extended versions of MMSC. Once we screen the person, once we detect the dementia, so we use some extended versions of MMSC like Edinburgh cognitive examination kind of test. Those are very time consuming, but which assesses many of the cognitive components of the patient. So having said that, we need to understand the limitations of the cognitive assessment also. So it will be very harder to establish the presence of establish the accurate score when there is illiteracy, dysphasia, sensory loss, and in people who do not speak English as a first language. If they do not have much fluency in the English, so it will be difficult because some of the tests are not validated to the local languages. So they are in their original language. So therefore, these limitations are there. However, we have enough resources which are validated to local languages to assess the cognition. This is the mini-mental test score. So we know that it is very familiar test. We assess 6 components of our major 6 components of our cognition. That is orientation, registration, attention and calculation, recall, language, and cognition. These are the 6 major areas. I'm not going to do the detail. I'm not going to detail these areas. That we assess 6 areas in later part of my presentation. I will compare the advantages and disadvantages of these commonly used screening tools. You can understand we give 30 marks in MMSC. So the cutoff, widely used cutoff is 23. If it is, if you score 23 or less than 23, you have cognitive impairment. But in the authorities have a debate. Authorities have come to a consensus that if somebody has higher educational level like university education and all, the cutoff should be little higher than 23. So some people say it is 25 for the very educated people. If they score less than 25 or less than 25, so we have to refer further for further advanced cognitive assessment. Then we know age at which with advancement of the age, their cognition declines, physiological decline is there. Therefore, very older people, we take cutoff as 20. So 23 is not a hard and fast rule. So that we have to adjust according to their intellectuality and their age. However, 23 is the widely used cutoff in MMSE. Yes, and in addition to that, we have to understand, as it is commonly used one, the MMSE has ceiling and floor effect. That what you mean by ceiling and floor effect is that if you score 30 out of 30, that doesn't mean that you do not have cognitive impairment, because it does not assess some of the component of the cognition. So people will have some cognitive impairment, but it is not assessed by MMSE, and they ceiling effect. Flow effect means that even you score 0 out of 30, that doesn't mean that your cognition is 0. So they have some cognition, because again, it does not assess some of the components of the cognition. So having said that, the next and little advanced than the MMSE is the Montreal Cognitive Assessment. Shortly we say it as MOCA. The MOCA is you can it assesses 8 components of the cognition. So you can see it is 8 components. So visual, spatial, and executive functions. You join numbers and letters, correlate to each other, and then you draw a cube, which is a little complex with some interlocking, and then you draw a clock, and then you name 3 animals. And memory, we check their memory, and attention, language, abstract, and delayed recall, orientation. You can understand we check their intellectuality and executive function as well as abstract thinking in Montreal Cognitive Assessment. So once we screen by using a brief test, then this Montreal Cognitive Assessment, MOCA, is a good screening, good assessment tool to categorize and categorize their cognitive impairment. So there are 8 components widely used as an advanced cognitive assessment method. So mainly the executive function and the abstract thinking process is assessed in Montreal Cognitive Assessment. So the MOCA covers more domains than MMSE, as I said, and it has greater sensitivity and specificity. So this is the abbreviated mental test score, the third screening tool that I am going to discuss. We ask 10 very simple questions from the patient. Especially we use this AMT, abbreviated mental test, in an acute medical ward to determine, to understand the acute cognitive impairment, especially delirium in elderly patients. We ask 10 questions, very simple questions: age in years, time of the day, name of the hospital at the moment patient is in, memorize an address. We give very simple address to the patient, and recognizing 2 people, like a doctor and the nurse, if the patient can recognize the person, and the current year, the 2021 is the current year, name of the state head, and that is the current memory, and the date of birth of the patient, and the memorable date of the popular, the memorable day, the Independent Day or the World War II starting day. So like that, and count down 20 to 1. That is the attention that we check. And then we ask the patient to recall the address that we given at the stage of 4. And number 4, we gave an address. We ask the patient to recall the address at the last point. So we give 10 marks to these 10 questions, 10 points. If it is 8 or less than 8, we take it as that patient has cognitive impairment. So it is the assessment of the delirium mainly we use, and we use this screening tool to review the patient. Once you diagnose delirium by doing other tests and the AMT, and the following day to see whether our treatment and our management plan is making the patient's improvement. So we assess the AMT, and it is very rewarding. They score more points in AMT in the review visit. So screening and review purposes, we use AMT. So it approximately takes only 3 minutes, but MMSC takes like 8 minutes. Montreal cognitive screening usually takes 15 to 20 minutes. So this is very brief test AMT. So AMT takes 3 minutes, but the researchers have validated this AMT into AMT4. Out of those 10 questions, we extract four very validated 4 questions to screen in a rushed emergency ward round, emergency department ward round, to detect delirium. So we ask the patient's age, date of birth, and the place where at the moment, and the year, current year. So if they can answer these 4 questions fluently, so it is very unlikely that patient, very less likely that patient got cognitive impairment in this visit. So then, if they can't answer one, so that means that the patient has some cognitive impairment. Then we refer the patient for the further assessment. So this is the 4th test, and a very simple test and widely used. Even our trainees use this test to assess their patients' cognitive cognition. So the clock drawing test. Clock drawing test is very simple. It doesn't the patient's ethnicity, intellectuality, and all these things are not affect. All these things not affect this test. So we just ask patient to draw a clock. So draw a cycle and put numbers as it is in a clock face, and you ask put on the hands of a specific time. The time usually we give is 10 past 11. So then if patient can do the cycle correctly, draw the cycle correctly, put numbers correctly, and put hands on the clock face correctly of the specific time, then we give 3 marks. So each point we give 3 marks. This is the clock drawing test. So you can understand here we detect their intellectual function, visuospatial, and visuospatial ability of the cognition. So, and constructional practices. Visuospatial, constructional practices, and frontal executive functions we assess in clock drawing test. It's a very brief test, but very useful test. So then we give 3 marks. So to say that patient is not less likely to have a cognitive impairment, they should score 3 out of 3. So it is independent of, as I said, intellectuality, the language they speak, and cultural ethnic factors. So clock is very familiar to each and every nation. So these are the clocks drawn by different stages of Alzheimer's. 1 is mild, 2nd is moderate, 3rd is severe Alzheimer's disease. So it's very important test. Then the little extended version of clock drawing, that is mini clock. In addition to what I have explained in the clock drawing test, we give 3 names, 3 unrelated names at the beginning of the test. We give 3 unrelated names like price, dough, and pen. Those are unrelated, different 3 names. And we ask the patient to remember these 3 names, and then we give the task of drawing the clock, like clock drawing. Once the clock drawing is finished, then we ask the recall 3 names that we have given before. So we give again 6 points there. So patient needs to score 3 or more to say that they do have less. They are having less, like they do not have cognitive impairment. It should be either 3 or more than 3. It is brief and minimum language and educational ethnic bias. So mini-cog. It is in a geriatric clinic, in a cognitive assessment of cognition. If we usually combine mini-cog with MMSC. So it both will carry more sensitivity than specificity one alone. So this is a brief comparing brief assessment scales, you can see. So the MMSC assesses 5 components, and there it takes 8 minutes. Minicock assesses, that is Minicock is the clock drawing and the recall test, which assesses 5 components. So it is just 3 minutes. So Minicock has a good sensitivity according to this, and the resources is pen and paper only. So then this is the last one I just wanted to compare with these brief tests. This is Edinburgh cognitive examination. It assesses many steps, many areas of cognition, and it takes 20 minutes, and it needs specialized people and many resources. So this is what I have explained so far. It is when somebody is having cognitive impairment, you can understand. So it takes me much time, more than expected time that we have to understand. So as we are dealing with many pediatric patients, we need to have patience with the patient when we are assessing the cognition. AMT is mainly for the delirium assessment. Clock drawing test correlates with the MMSC, but the sensitivity and specificity to detect dementia appears to be a little lower than MMSC. That we can understand. MMSC is detailed in 6 areas, and clock drawing test does have some capacity to detect the frontal executive cognitive abnormalities in people with who score normal. Normal MMSC people with normal MMSC will carry less marks in clock drawing test because it detects executive cognitive abnormalities. And then the other thing is that we use cognitive assessment tools to distinguish causes of impairment. Here, I should stress that it is just not a tool or a scale or a score. It is just comprehensive geriatric assessment. It should be comprehensive assessment of their cognition. We need to take a good history. As patient is cognitively impaired, it should be the relative caregiver or the closest family member. Then the thorough physical examination to detect any hidden signs like Parkinson's. If somebody is having cognitive impairment and Parkinson's, you know, it pointing towards Lewy body dementia or Parkinson with dementia. So then the history will be important to differentiate, and some investigations to detect alternatives as well as potentially reversible causes. Like we do vasculitic screening, vitamin B12, hemoglobin, TSH to detect hypothyroidism, and imaging to see if there is space occupying lesion, hydrocephalus or subdural hematoma. So these things also dementia mimickers. And then the distinguishing causes of impairment. So we use after doing these comprehensive initial assessment, then we use assessment batteries. So depression will be dealt by Dr. Kapil Ranasinghe. We should not forget depression. It is one of the major areas of cognitive impairment. So geriatric depression score is the one mainly we use in our clinic. So then the delirium, we use cognitive confusion assessment method, CAM, where we assess 4 areas. Dr. Shahani Silla will be discussing with this. And then the dementia, where we assess, where we do informant question. These are advanced things. Informant questionnaires, frontal subcortical assessment battery, extended versions of MMSC I discussed few times. And we combine clock drawing test and MMSC or Edinburgh cognitive examination. I'm not going to be in detail of these things, but we need to know these tests are available when necessary. We have to refer them and we have to assess our patient accordingly. And then some qualitative assessments are there. In addition to those scales, we assess attention by reciting reverse sequences, like, and list the month of the year backwards. We assess attention in those methods, and memory, of course, episodic, semantic, and procedural, and working memory we assess in different ways. So language, dysarthria, comprehension, paraprasia, we assess separately if we have any concern about those areas, and visuospatial skills, and we ask copying the diagrams like interlocking pentagons. MMSC, we do that. So these are the qualitative assessment methods. And frontal executive function, planning, abstract thought, judgment, we assess by different ways. So that I just want to tell these things are these things also we need to use to assess their isolated areas of cognition. So asking the patient to interpret proverb can assess abstract thought. That we in our clinic we use that. We just ask proverb and we ask them to interpret the proverb. Finally, the integrated care of older people, ICOPE, that is the WHO collaborated program where we were trained as master trainers to screen geriatric people of their major cognitive problems, geriatric giants, cognitive impairment, incontinence, instability, falls, immobility, and polypharmacy. All these major geriatric problems are being assessed by ICOPE assessment methods, where the cognitive assessment also dealt there. So first we ask whether you have in the ICOPE assessment in our ICOPE clinics, integrated care of older people clinics. First, when we encounter an older people, we ask whether you have any concern about your cognition, or their relation. We ask whether you have any concern about your cognition. Then if they say yes, of course, then we direct them to the advanced assessment of their cognition and cognitive capacity. If they say no, we just ignore the patient. We can't just ignore the patient. We just ask 3 questions. And that is very simple, like AMT4. Remember, we ask the patient to remember unrelated 3 words like pros, price, and do. And then we ask the patient's orientation, 2 questions. Where do you now at the moment, and what is the complete date today? Today is the 2nd December 2021, Thursday. That we need the complete answer. Where do you now? I'm at New District General Hospital, Mater. So we need to have a complete answer. Once we ask 2 orientation questions, then we ask to recall the 3 names that we have given at the beginning. So if they can't complete this test, then of course they have some cognitive impairment. That part also they direct to the advanced assessment of their cognition. So that's how, as primary care physicians, the GPs and other primary care physicians are trained to collect and screen geriatric patients who do have cognitive assessment. So that is the last of my presentation. Then I will draw these conclusions. Screening tests are available that is the presence of cognitive impairment. I have discussed many. There are many thousands of validated tools, but I could not discuss everything. And brief tests with reasonable sensitivity and specificity are Minicog. Minicog is a good test, as I discussed. And typically, shorter tests do not assess frontal executive functions, but brief tests are important for the screening purposes. And the best method of classifying causes of cognitive impairment remains comprehensive clinical evaluation, history, examination, and investigations, then cognitive assessment tools. The most suitable technique for a given situation will be judged by the time available and diagnostic accuracy required. And the purpose and the time will come first before you decide which assessment tool that I am going to use. And be familiar with the advantages as well as disadvantages of the various techniques. And all doctors who treat older people should be able to administer a short cognitive screening test, at least AMT4 to assess and screen for the cognitive impairment in older adults. That will be the end of my presentation. I would like to thank you all again for the patient listening.
Thank you, Lasantha. Yeah, thank you, Lasantha, for that very important and informative lecture. I think that is very, very important for the physicians who are doing a busy ward rounds in day-to-day activities. I would like to introduce the next speaker. He is Dr. Kapila Ranasinghe. He is a consultant psychiatrist at National Institute of Mental Health. And he will be speaking to us on behavioral and psychological symptoms of dementia. Over to you, Kapila.
Thank you very much for the kind introduction. Let me share it. So I actually thought of behavioral and psychological symptoms in geriatric care because although the term was initially introduced for dementia, behavioral and psychological symptoms, they do occur in a large number of neurocognitive disorders, which are not necessarily dementia. That is the current understanding. Even last few years, there are a lot of attention. Any geriatrician will be seeing behavioral and psychological symptoms, even with mild cognitive impairment or without any cognitive impairment at all. The new developments are interesting, but as we all know, it mainly happens in dementias. Interestingly, in our part of the world, it is the behavioral and psychological symptoms of that actually leads to consultation mostly, because they find it difficult to keep their loved one, the elderly person, at home. And we are well aware, behavioral and psychological symptoms consider major component of dementia syndrome, irrespective of its etiology, or the type of dementia. And as I said, it's the main problem for carers and service providers. In any ward who's giving dementia care, in my wards, this is the main problem, not the cognitive impairment, the complaints from the nurses, the carer, the family, mainly the behavioral problem. And the current understanding is 97%, that is almost all of them are having this problem. And they are also called neuropsychiatric symptoms, depending on the country that they use it now. Most of the Americans, North Americans also prefer neuropsychiatric symptoms, because the word is interchangeably used nowadays, because the fact that I told it can happen in any geriatric patient. So that mainly the word is NPS, confined to cognitive normal people nowadays, right? And it can be the first symptom in appearing some disorders like Alzheimer's and Parkinson's. This is the type of behavioral and psychological symptoms you see in geriatric care and dementia patients. You see that they occur in clusters, right? From apathy, depression, agitation, aggression to mania to psychosis, right? And the apathy can be characterized by withdrawal, lack of interest, demotivation. Similarly, psychosis can be any type of psychosis, agitation, same. So usually, if there one part of the cluster is there, other thing can be there. So, for example, somebody deluded, unlikely there can be suspicion, misidentification, a lot of psychotic symptoms can be there. So I'm not going into a lot of detail because then it will be coming again and again to the symptomatology. But the important thing is, this is BPSD is actually associated with greater functional impairment. This is the thing. Other thing, the cognitive impairment usually correlates with the behavioral and psychological symptoms, but in non-demented patient, it may not correlate, right? But it's very clearly associated with functional impairment, and it leads to institutionalization, accelerate dementia, and causes caregiver stress. A lot of caregivers get tired, exhausted, depressed, and it's the main marker of poorer quality of life. And it has an increased risk of death because of the falls, other morbidities are increased, and more neuropathological markers of dementia are seen when they are demented. These are the CACHE study, 2019. I mean, for academic purposes, I highlighted this. High prevalence, right? Even in normally, cognitively normal old adults, there's around 15%. And cognitively impaired, no dementia again high, and dementia is very high. Right? In people with dementia, at least one clinically significant behavioral and psychological symptom is predictive of progression of disease to the severe illness or the death. This is a marker that we need to understand that dementias are end-stage diseases in life. So unless you start all the treatment from disease modifying to management of proper management of cognition, behavioral, psychological symptoms, the total package is needed to alter the cause of the disease. It's a deadly disease otherwise. In cognitive normal adult, total burden was associated with longitudinal cognitive impairment. These are the same finding. You see, the CACHE study findings are interesting. They have apathy, sleep problem, irritability, persecution, depression, misidentification, hallucination, wandering, elation, agitation, anxiety, and confabulation. There are a fair number of people without dementia having, but you can see very clearly when it goes to dementia, there are very significant numbers, right? One of the, I think the highest problem is apathy and irritability and psychotic symptoms. We manage in Sri Lankan setup also, we studied some time back. This is our own study. People who are getting to the getting at the geriatric unit environment. This was done 2015 and 16 and presented in the Royal College of Psychiatrists. A lot of our patients are also having remarkably high number of psychotic symptoms, delusions, then depression, as Lasantha told you, very high. Dyskinesia, irritability, all the symptoms that are usually seen in the other part of the world are also seen in our countries and admissions. Then associations are very interesting. You can see the memory impairment, subject impairment has a higher prevalence of symptoms. And vascular morbidity is associated with the increase of other mood symptoms, right? And co-occurrence of symptoms also noted. Hallucination and misidentification, anxiety, apathy, and depression, irritability, persecution, and wandering. That's why at the beginning they usually occur in clusters. And even in our study, we did the fact analysis and showed if the anxiety comes, it can go to more great anxiety and then depression. The clustering pattern we showed even in Sri Lanka. Now, coming to depression. Late life depression is associated with brain disease. It is the norm now. Coming from Parkinson to mild cognitive impairment, dementia, Alzheimer's, vascular dementia, Levy stroke. So if somebody is getting for the first episode of severe depression, you have to suspect at least ischemia. It is organic. I think when we were learning, there were no major MRI studies. We used to learn this, it's called vascular dementia. Sorry, vascular depression or mass depression. They were kind of depressions that were associated with brain diseases. Now we have clear understanding what are these disorders, and so this assessment have to be very specific, as Lasantha told, and it is a very extensive assessment leading to neuro, which is covered by in our talks. Then ischemic. Right, white matter hyperintensity are especially prominent, right, in the frontal lobes and basal ganglia and subtle. Sorry. Right. Neurological abnormalities and reductions in pyramidal cell volume may be present in key areas of the frontal subcortical circuit. All white matter hyperintensity in depression was ischemic, as opposed to non-depressed and associated with vascular. This is I'm a psychiatrist, so when depression is treatment refractory, we nowadays almost always go for an MRI. Then clearly we easily detect this hyperintensity and ischemic area. So then you have to tackle the ischemia with a lot of difficulties. Then only they develop. So treatment resistant in old age is very clearly associated with this. And in about 50% of late life major depression, vascular disease is the important factor. This is in the Oxford textbook of psychiatry. They have highlighted a large number of studies. Then the other important thing is the apathy, and it's evident in 3 domains, either goal-directed behavior, goal-directed cognitive activity, or emotion. They are we usually measure it like hyperactive delirium, very quite slow and not interested, right? But only with clear mental state examination, you will be able to identify that it's distinct from depression, and closely correlates with agitation and depression. So this is not easy business. Some of them are severely depressed, apathetic as well. As once you start treating depression, all the apathy will start manifesting. Then apathy diagnostic criteria, right? It has to be assessed relative to the previous functional levels and not attributable to intellectual impairment, emotional distress, or diminished consciousness. Emotional distress is absent, must be present most of the time for at least 4 weeks. Minimum of 1 symptom should be evident from 2 of the behavioral, cognitive, and emotional domain. And the apathy should cause clinically significant functional impairment. They will say that they don't have the energy. Even the carers will say that even the feed, they don't have take any initiation. And differential diagnosis is important because some of the medications that we use can cause apathy, right? Like antipsychotics, antidepressants, neuroleptic, other neuroleptics can fatigue, lethargy, restlessness, and reduce response to medication. And the other interesting the chances don't miss depression, hyperactive delirium, and daytime feverity, insomnia. And a lot of other beta blockers, many cardiac drugs can cause like symptoms, right? Androgen blockers. So you have to, assessment is apathy is quite difficult in old age. Management is quite difficult again. Evidence is limited. So it's they talk about multisensory stimulation, VR, game-based stimulation, OT activities, stimulation, creative activities, cooking, Montessori methods, physical exercise. What we have seen, assisted physical exercise and engagement and stimulating activities, they do help. Then pharmacotherapy, again, is difficult because associated side effects, right? When it's very severe, one can tie methamphetamine, which is usually used in children, the Ritalin, and the improvement is not great. But if there are traumatic brain injury, post-stroke, the response is better. And antidepressants again give very mixed results. Then coming to manic symptoms. It may occur in the context of bipolar affective disorder, or from young age to the late onset, early onset depression connected to bipolar type, the treatment, second, right? And late onset is most commonly secondary. If somebody is getting a manic symptom in very late life, after 65 or 75, the chances of it's more secondary causes. And associated with increased cognitive impairment. Prevalence is common is 0.6% in above 65%. So it's a rare compared, but depression is the most common, apathy and the most common one. And late onset manic symptoms, elderly may have less classic manic symptoms. And there are mixed episodes, very difficult to identify. Most evidence for vasculature. And so if you again the assessment, quick comprehensive geriatric assessment and MRI is important because increased white matter high density sarsia, more vascular involved in the deep frontal and parietal lobes and putamen. And DD again, right? It can be pure dementia syndrome, vascular mania, traumatic brain injury, slow growing tumors. And interestingly, even in our setup, we have detected slow growing tumors, especially temporal lobe epilepsy like, and HIV, metabolic disturbances, endocrine disorders. So it's assessment is quite has to be very comprehensive. And steroid. Now, after the recent COVID pandemic, we start seeing steroid induced manic because most of them are survivors, long COVID survivors were on steroid high, and they were going very high. It was kind of difficult to keep at home. First episodes. And management again, thorough evaluation, low dose antipsychotic, very important because they are elderly are very sensitive to neuroleptics. They can fall, get oversedated, and a lot of even go to delirium if you unnecessarily high doses. And again, mood stabilizers have to be very cautiously given. All the mood stabilizers, lithium, valproate, lamotrigine can be highly toxic in elderly, so it's starting low dosing, gradually titrating is important. Anxiety symptoms. Anxiety is a much more common than anxiety disorders, and it's regulated by the limbic system. It's associated with increased rate of conversion from mild neurocognitive disorder to major neurocognitive. And when there's anxiety disorder, there's almost always comorbidity, either diabetic, hypertension, dyslipidemia, ischemia, heart disease, arthritis. All these comorbidities are highly associated with anxiety disorders in elderly. Again, differential diagnosis is very important. A lot of Alzheimer's can start with anxiety symptoms in preclinical stages, and is associated with cerebral amyloid load. And medical illnesses, again, as I told you, then Parkinson is the highest rate, I guess, and the medication induced. So it's iatrogenic, some of the anxieties are. The management, first thing is to address the medical cause, then substances, medication. Anxiety is actually improved by physical exercise and activities and relaxation activities. So elderly can be also taught initially relaxation activities and restore sleep, sleep hygiene, good therapeutic relaxation, education, and very specific relaxations can be in, and behavioral CBT if they are educated and have the organized lifestyles. Then medication is the last option. Obvious reason. The agitation is again a behavioral symptom which is associated with increased motor activity, restlessness, aggressiveness, and emotional distress. And they all have a frontal lobe dysfunction, anterior cingulate cortex or orbitofrontal cortex usually, and often accompanies psychosis. So agitation, psychosis is coexistent like a large number. And dementia, 30% increase of with the risk. Treatment of agitation, again, behavioral measures should be tried first, but easier said than done. So somebody has to well train occupational therapists, nurses, icon. Then antipsychotics recommended risperidone, aripiprazole, and quetiapine if it's essential to use it. And some meditations associated with anxiety, depression, also improve with selective rehabilitative low doses. Again, you have to be very careful. SSRIs are nasty in causing loss of electrolyte imbalances. So all these antipsychotics and SSRI, we have to start slow, monitor, and carefully titrate. Coming to the green monster of Olelica, the psychosis. Psychosis is the most difficult part to handle because of their vulnerabilities and sensitivity to antipsychotics. And it can be due to possibility of primary psychosis, early onset of schizophrenia, very late onset schizophrenia, affective psychosis, delusional disorders, or secondary psychosis. And it's important to remember that 60% of psychosis in elderly are secondary. Delirium, neurocognitive disorders, neurological disorders, medications, substances, especially in Parkinson's and other movement disorders, it's due to medications. And DDs, you should consider Alzheimer's, vascular dementias, and the highest possibilities everybody knows by experience can be the dementia of Levy type or delirium. And Parkinson's disease, right, itself can have a complex hallucination and Huntington's. That ends my discussion. Thanks for your attention. We'll be answering questions the trainees are having in the Q&A session. Thank you.
I'm Dr. Shayan Silva. First of all, I would like to thank on behalf of the Sri Lankan Association of Geriatric Medicine, to the Ceylon College of Physicians for giving us this opportunity to conduct this specialty update. And I would like to take the opportunity to do something on behalf of the president of the association, Professor Sarath Lekambasam, who is not able to make it today because of another commitment in the university. So we have come to the midpoint, and we are delighted to release our 6th bulletin. I hope you can see this. We released this booklet or bulletin on healthcare for older people, holistic approach. And this time the bulletin is based on mental health problems in old age. And I'm happy to say that with myself, Dr. Madhushani Dias, who is Senior Registrar in Psychogeriatric Medicine, we have been able to edit this document, and we have a large panel of contributors who have sacrificed their time and very nicely written articles in this book. And we released this book, and I present it virtually to Dr. Shamita Dasanayaka, who is in the other room virtually, from secretary to secretary. And thank you. And we also wish to tell you that this book, along with the other booklets that we have released in the past, is available for sale at our office in at Vijayarama House at the Sri Lanka Medical Association. So this book is for sale for 500 rupees. Thank you.
Yeah, thank you, Shehan. And this is the book that I received. Thank you so much. And we will give the publicity for this through the CCP as well. And my next task is to invite you for the next topic. The next speaker is Dr. Shehan Silva. He's a consultant physician and a senior lecturer in medicine, University of Jawaharlal. And he will be talking to us on delirium. Over to Shehan.
Thank you again. And without much ado, I will move on to this talk. I hope I will do justice. So my talk will be on identifying delirium, to identify precipitants and contributory factors, and to see how assessment could be done. And most importantly, about management of delirium. So I start off with a case. So there's an 80-year-old lady who is at an elder's home, and she's detected to have change of behavior going on for 2 days. She had been pretty much well before, except that she has had dementia, high blood pressure, depression, and osteoarthritis. So this change of behavior of 2 days duration is in manifestation of boisterousness. There's abusive language, there's refusal of food, and there is somewhat assaulting of caretakers. So it's a fluctuating condition that the caretakers reveal, where there are spells that are very excessively worse, and then there are times when the patient is placid, but it is with fluctuation. So the patient is on many medication, including losartan, indapamide, which is a diuretic, thiazide diuretic, atorvastatin. She's on 2 drugs for dementia, donepezil and memantine, and also fluoxetine for her depression. So with the assessment, the medical team finds out that the patient is having a sodium of 115, and the creatinine is also high. So the management requires that there is a correction of hyponatremia. I'm sorry that I haven't typed in chronic kidney disease as well. The acute on chronic kidney disease is also important in the management here. And there are some medication that may cause a syndrome of inappropriate ADH secretion leading into hyponatremia, which would be helpful in management of this patient. And then, of course, a non-pharmacological approach. We'll talk about this as we go on. So this is some sort of a scenario that we would come across in our medical wards, as well as maybe in the psychiatric wards as well. So what is delirium? So delirium is an acute and fluctuating syndrome. So it's not just one single baseline as like what you would see in a patient with dementia over a day. Dementia, as you know, there will be some sort of a deterioration in the long term. But in delirium, it comes acutely, and there is also a fluctuating pattern during the daytime. And there is altered attention, altered awareness, and altered cognition. Dr. Lasantha nicely spoke of cognition. And thereafter, there are some other concepts about attention where there's the consciousness should be fixed on certain thing without having a wavering mind. And most importantly, then there is alteration of awareness or sense of presence. And this is precipitated by an underlying condition or an event. This is where we as physicians come, or even any medical officer or any specialist should be wary of, where the precipitant should be detected. And this occurs in vulnerable persons. So you may think that delirium comes in older adults. Not so. It can come in any kind of individual, even in the middle age, but also in children as well. And there are various other names, such as altered mental status. We call delirium as acute confusional state, sundowning, encephalopathy, or acute organic brain syndrome. I believe the Sinhala term is Vibrantia, which is again a very deliriogenic word. So we think that delirium is something which cannot be understood well. So this is a collage of image which has been made by a person who has taken into account the way that a person who had been in delirium had described. So you see that the patient is lying on the bed. There is a ball, there's an apple, there is a doctor who is like a movie star. There's a tree and there are people on top of a tree. Then this patient sees the world spinning around, and there's King Kong and various things. So you see there's a lot of stimuli which generates disorganized thinking coming into play. So this is where we come in. We need to know that the patient is the sufferer. So it's not just a collection of symptoms or signs or disorganized functions or damaged organs or emotions, but we need to realize that we are dealing with a human who is fearful, who needs hope, who is seeking relief, help, and reassurance. So talking about delirium is more prevalent, and it is there are increased incidence as well in the hospitals. You see these figures. At hospital admission, it comes to about 10 to 31%, and with surgery, it goes up greater, particularly with orthopedic surgery. And while a person is there in hospital for a prolonged period, the rates go up, and this is seen especially in environments such as ICUs, where there is a lot of stimuli, where there's a lot of change in the environment, the temperature, the ventilation, the lighting, etc. And we'll talk about that again when we're talking about non-pharmacological management, and also in the community and in long-term facilities. So how do you detect delirium? So we spoke of various things like other cognitive assessments like MOCA, Edinburgh's method, and MMSC. So the easiest way of doing is by using for delirium, as in assessment of delirium, is confusion assessment method, where there are 4 features that come into play. Number 1, as I mentioned before, the acuteness and the fluctuating cause, which should be followed by inattention, not being able to fix onto a single thought. This, along with either disorganized thinking or altered level of consciousness. So mind you, you have to remember, it may be either disorganized thinking or altered level of consciousness. This in synchrony will point out towards delirium. And you see that the sensitivity and specificity has been shown to be quite impressive. So we need to be wondering whether there is an acute change in the mental status from baseline. So the way that the patient was in the community, like our lady in the case 1 who had dementia, who had a baseline which was sort of placid, but suddenly there had been an acute change. Or did it occur with some sort of a fluctuation where there is sundowning, or during the evening it worsens, or during various certain times that it changes up and down. Moment, or if there's easy distractibility and difficulty in keeping track. Is this the case? That is inattention. Third thing is disorganized thinking, like this painting Scream, which was drawn about somebody who is going through a difficult period. Is the speech or thought disorganized or incoherent? Is there a lot of rambling, unwanted things, irrelevant things going on? Is there unclear or illogical flow of ideas, whether it's not overlapping with each other? Maybe talking about, let's say, some food, and then the patient is talking about going to the market, and then talking about going to the toilet or something like that, where there is not a logical flow of ideas. And whether there is unpredictable switching from subject to subject without any kind of following precedence, the patient changes the topics from time to time. Altered level of consciousness. This again is another talk of its own, but quite a very area of a enigmatic proportion, where it's again a spectrum from alertness, from vigilant, being hyper alert, to becoming lethargic, but being able to be aroused, having stupor, which is difficulty in arousing, and having complete unarousability, like in a coma. So these are things that we need to be wary of. Other than the CAM, there is also a criteria, a set of criteria, the DSM-5. DSM is again sort of like the Bible of the psychiatrists, if I'm not mistaken. So there are 5 areas that we need to wonder about: attention and awareness, as we spoke of, about the development of something in an acute form from the baseline and having fluctuation, and about disturbance in cognition. Cognition as in memory, orientation, language, visual spatial skills and perceptions, which Dr. Lasantha spoke of. Along with that, if do criteria A and C, attention, awareness, as well as cognitive problems, are they not explained by the pre-existing problems? The pre-existing dementia may not be the issue where the patient has acutely deteriorated, or is it if it is not explained by the established problems, like established psychiatric illness, maybe schizophrenia, or manic illness, which causes a sudden surge of change of behavior. And also, we need to be wondering whether there are any secondary causes or underlying causes giving rise to these pathological manifestations, which would be harnessed by a history examination or by investigation. This is a complicated slide. I'm sorry that some certain words are in small print, but this is actually the modern thinking of delirium, where the hypothesis is called systems integration failure hypothesis of Melando. There was a nice talk at the last American College of Physicians meeting, which was held virtually in April, and this was put out, which was spoken of nicely. There are 5 elements in this which come into play in unison or in singularity, where there is neuronal aging. As one advances in age, there is atrophy and there is changes in the brain. There is neuroinflammation, where there's a lot of cytokines that may be coming from illnesses that we were speaking of, or the oxidative stress, again from the illnesses that they come. And there can be neuroendocrine dysregulation from the hypothalamo-pituitary axis. So you see there's a lot, the neuroendocrine, the nerves as well as the hormones come into play, stress hormones in particular. And if there's a derangement, that also contributes. And also the circadian dysregulation, or our biological clock. That is where the thing about confusion of the environment, such as an ICU setting, comes in, which we will talk about. So all these can give rise to delirium or acute brain failure, and they will result in morbidity and mortality. So delirium occurs in many shades. It's not just only clear-cut, it's not a clear-cut pathological state. One could have hyperactive delirium where the patient is excited, or that is called very, very psychotic or excited, from restlessness to being agitated, uncooperative, and very, very dangerously combative state. Or the patient could have a hyperactive delirium, which is sort of a withdrawal state, having cognitive impairment, maybe coming with a tone of depression, lethargy, obtundation, and resulting in sort of a catatonic state. So between these two ends, there can be a fluctuating cause, or which we call as mixed type delirium. So you see, you need to be sensitive to these types of presentation. I guess hyperactive delirium is sort of the more easily detected type of delirium because it is more clearly manifest. But then again, a lot of people may miss out mixed type of delirium or hyperactive delirium, especially when they come with some sort of infection. There are other scales as well which would be useful. I won't dwell on them too much. This Richmond agitation and sedation scale is useful, where initially one could approach the patient with regards by voice, in the form of talking, and one could grade from 4+ to -3 depending on whether the patient was combative or moderately sedated. If somebody is in deep sedation or unarousable, that person need to be assessed by touch or by physical examination definitely, and one needs to find out whether there is an underlying problem which is beyond delirium that is going on. So we come to the second case, a 75-year-old male who is currently being treated for bipolar disorder and hypertension, which have been going on for maybe about 10 years. Over the past 2 days, the patient is refusing meals, is poorly talking, is unaware of what is happening, and sleeping. And the Richmond agitation sedation scale is -2, that is lightly sedated, briefly awakening to voice. There are fever spikes, and the ward staff notes that the patient is having smelly urine and is doubly incontinent, stools and fecal incontinent. Patient is commenced on treatment for urosepsis with intravenous antibiotics, but despite optimal treatment, there is poor response by the 3rd day. So you look at the medication and you see that the patient is on olanzapine, lithium, amitriptyline, and also amlodipine. So a detailed history and examination needs to be looked into to see the predisposing factors as well as the precipitants. And you see that there's unresolved urinary tract infection and poor intake of food. There's a hand cellulitis at the cannula site. There is a restraint, although we have not tied the patient to the bed. There's a restraint, the urinary catheter. That is something that we need to be aware. There is a new paid caretaker, maybe from Sadasarana, who has come, and the patient is confused of this new person. And there are certain drugs which can cause hyponatremia, as you see, the olanzapine and even amitriptyline, and the patient is having underlying prolonged QT because of the medication, the psychiatric medication, and that is worsened by the amlodipine, the calcium channel blocker. So this patient, unlike the first patient who had hyperactive delirium, this patient had hypoactive delirium. So what do? If you come across delirium, you think of delirium. So there's a mnemonic here. D stands for drugs, especially anticholinergics, steroids, opioids. Patient may be having dehydration. E stands for electrolytes, especially the notorious ones are sodium, low sodium levels, maybe high calcium levels. You know that with high calcium levels, you get bone stones, Crohn's phenomenon, and also even hyponatremia along with dehydration. Emotions, pain, fear, anxiety. We tend to forget this in our clinic setting. L stands for lung and liver. Maybe underlying pneumonia, pulmonary embolism. Maybe the patient is having a hepatic encephalopathy. I stands for infections, significant reason for delirium. UTI, cellulitis, meningoencephalitis. R stands for restraints. As I mentioned, it might not be just by being bound to the bed, a catheter or NG tube, or even the other R of retention, urinary retention, constipation, or stool impaction. The second I stands for brain mets, strokes, and seizures. So with regards to the brain, and also infarctions. U stands for uremia, and M stands for myocardial infarction and metabolic problems, especially hypoglycemia and alcohol. So one needs to be wary of these precipitating factors like dehydration, poor nutrition, hypoxia, ischemia, critical illness. We spoke of fractures and orthopedic surgery, which is associated with increased incidence of delirium, pain, infections, retention, and also ICU. Especially, we need to be concerned about the change of environment, especially the hospital, where there is a lot of noises coming from the healthcare workers, doctors, nurses, attendants, the trolleys, and various other things like procedures that are done on patients, which causes a lot of noise. Poor lighting, lack of windows causes an absence of day-night differentiation that will give rise to the alteration of the circadian rhythm, which we spoke of in the system failure hypothesis. Frequent staff and room changes. Patient is shifted from ward to ward, general ward to cardiac ward, from the cardiac ward maybe to a surgical ward, and ultimately to the general medical ward. And again, frequent staff changes, shifts, and also various new people coming into the management and restraints. This is another picture, a painting of a person who is old and who may be undergoing delirium. You see that there's a lot of people coming in, the family, the extended family. You see that there are healthcare workers coming in. The hospital administrators may come with bills. There may be clergy people coming to address the spiritual health. There may be other people, other visitors who come. So you see there's a whole heap of new things happening for the patient. Again, can lead into confusion. Other predisposing factors include advanced age, being male, having a terminal illness, we spoke of this, and then the geriatric giants like dementia, depression, polypharmacy, ulcers, sensory impairments, and in particularly the pre-morbid states like being person who is inactive, being in one place, being bedbound, who has a poor functional status, and have social isolation. So these are some of the medication that can cause delirium, especially the anticonvulsants, the antihypertensives like beta blockers and calcium channel blockers, certain antihistamines, sedatives, tricyclic agents, anticholinergics, which have higher risk, especially the antipsychotics, the dementia drugs that are commenced on patient, benzodiazepines, and dopamine agonists. So one need to be also wary of delirium and dementia. So you see that delirium is an acute event, whereas dementia is an insidious effect. Delirium, there is altered consciousness, but in dementia, you see that the conscious state is intact. So altered consciousness is one of the important things in the CAM, but in dementia, the conscious state is intact, and the fluctuation is not seen in dementia. Hallucinations may be present in delirium, but hallucinations are absent in dementia except for Lewy body dementia. And you see that in delirium, there are shades of hyper or hyperactivity, but dementia, they may not have psychomotor disturbances. And the good thing about delirium is it is reversible, whereas in dementia, it is rarely reversible. Other differential diagnoses include depression with hyperactive delirium and also mania with hyperactive delirium. So what do you need to do? You need to address the risk factors and precipitants, need to take a history examination and find out what the cause is. There may be multitude causes, so those have to be attended to. But more important, you need to also look at the other things like medical nursing, encouraging the patient to consume liquids adequately. The fluid balance needs to be done in a judicious way, especially if there is evidence of chronic kidney disease, chronic liver disease, or chronic congestive cardiac disease. Patients' nutritional supplementation has to be attended to. Patients may be malnourished. Think about refeeding syndrome and think about managing the caloric intake. That's a topic of its own. Culturally sensitive meals should be given. Patient may be a vegetarian. We may offer chicken soup, which may not be appropriate for the patient. Properly fitting dentures and a conducive environment to eat. Look at our wards. There's so much of disturbance in the meal time and non-meal time as well. Sometimes the patient's eating area, I just noted that even in my ward, it was like that. The eating area is next to the toilet. So how much of conduciveness is there? Odors and as well as noise. So in UK, there is a mechanism for this where if the patients are not able to eat, they have a red tray pathway where they highlight those people who can't eat and they give more time and more help and encouragement. So the red tray, unlike a blue tray or a brown tray, will be a signal for the healthcare assistant to help the patient to eat. And at the front of the ward, there is a notice which says, we have a protected meal time. Don't come from this time to this time. Let the patients have their meals. It's essential that simple things like dentures are addressed as well, which will improve the mastication and the swallowing. Look out for hypoxia, improve the oxygen delivery. Make sure that the patient is back on her feet. Early in mobilization and active motion is important. Infections need to be addressed, judicious use of antibiotics or any other ancillary treatment. Avoid unnecessary interventions like catheterization, NG tubes, etc. If the patient is having problems with sensory inputs like hearing problems or vision, hearing aids, spectacles, sometimes there may be impacted wax. So those need to be addressed too. Sleep, again, promote sleep hygiene. Avoid procedures that during sleep time, sometimes we go and wake up patients. The time that we would do our lumbar punctures will be the time that the patient may be having a nap around 2 to 3 o'clock. Are we aware of this? Are we taking into consideration? Schedule of medication rounds. We need to be a little bit more careful of the patient's patterns. Noise during sleep, and make sure that the sleep-wake cycles are maintained and the patient is not going for just simple power naps. We need to address the caregiver and the healthcare workers, not only ourselves. We have to take care of our own nurses, our attendants who are looking out, who may be abused by the patient's combative state of mind. The family, they may be drained and they may be in burden. There is apprehension, there is anxiety, exhaustion in all these people. So the caregiver burnout and resources must be explored, and there should be some sort of a practical way that we could help in some, as advice. And more importantly, let's get our paramedical people, the nurses and the therapists also into the equation. Are we getting them as a multidisciplinary, comprehensive geriatric assessment for the care of our patients? Combativity and agitation is challenging. It results in falls, wandering. There is inadvertent harm because the patient may go and injure himself, may knock his head, may cut his arm, etc. There may be therapeutic disruptions where saline, etc. will not go on, and physical and verbal abuse may be present. So these symptoms have to be controlled to make sure that the harm is not done. So non-pharmacologically, mild symptoms, you need to use your interpersonal and environmental manipulations done. May be difficult, but we need to try out. Establish special units, geriatric units or older adults friendly units where we could manage these people. Frequent and patient caring reassurance. Patience is essential for the patient. The therapeutic touch, how much do we go and touch the patient and explain certain things? That makes a huge difference. Verbal orientation. Also, if there are delusions and hallucinations, do not go and enforce yourself and say, no, this didn't happen, or this, you shouldn't talk about it. Don't go to endorse it or challenge it. Just go with the flow and try to calm the patient down. Do not go and have any retortion. Restraints, again, an issue. A lot of problems are there in psychiatric wards as well as non-psychiatric wards. Should be used as last resort because it increases agitation, worsens the mobility, and causes things like pressure ulcers, aspiration, and causes prolongation of delirium. So there is a virtuous cycle and a vicious cycle. So as you see, the vicious cycle is with restraint. There is bad thoughts, bad delirium, agitation, pain, all going round and round. But if you remove the restraints, reduce the sedation, you speak to the patient, touch the patient, and you explain, and you see that there is collaboration and delirium would go down. Do we make ourselves mindful of how we restrain the patient? What we usually see is that patients are restrained upon this bar. the sidebar which can be put up and down. So you don't do that because that is something that would worsen or increase the harm of that patient. So you need to, if you need to restrain, you need to restrain to the frame of the bed rather than the bars. And you see that there is some element of change in the posturing of the arms. One arm should be down and one arm should be up, so that patient is able to be comfortable. And the head should be raised 30 degrees. You prevent aspiration in such a patient. Briefly, a little bit of pharmacological management. Cautious trials may be used. Things like haloperidol can be used as needed. Continuous prescription is not recommended, but as needed, one could give drugs like haloperidol in the form of intramuscular, intravenous, and subcutaneous methods as well. But be mindful of the side effects, especially electrolyte abnormalities, the QT prolongations, etc. And there's a whole heap of other drugs like levomepramazine, risperidone, olanzapine, quetiapine. Be mindful of prolonged QT. Prolonged QT is something that we miss out in this country as physicians mainly. We do not look at the QT interval when we get an ECG, and patient can have a lot of deleterious effects. Look out for extrapyramidal symptoms and benzodiazepines. We may give things like diazepam, etc., to sedate the patient, but it should not be given with, there's poor evidence and it has been shown to be associated with worsen outcome. Cognitively impaired patients, you need to have consistency in healthcare, limit the number of staff, minimize the turnover, as I mentioned before, good lighting, clear signage, have good working environment for the patient, have a clock and up-to-date calendar so the patient knows what is happening, orient and reorient the patient regularly, and have one-to-one care if possible. These are some things that can be done. We don't go and introduce ourselves to the patient, not even once or even during our ward rounds. So this "Hello, my name is" campaign was initiated in the NHS UK, where it was shown to have an improvement in the level of confusion in the hospital reduction. Pain, do we look at the pain with regards to a score like this, and do we go into an appropriate pain management strategy? Do we address risks for immobility and confusion like aspiration, orthostasis, thromboembolism, screen breakdown, sarcopenia, and deconditioning? So these are things that the patient could have going on after delirium, which will worsen the length of stay. And you see that there is a cycle of deconditioning. Prolonged bed rest will result in deconditioning, and the patient will have reduced muscle strength, going to confusion. And then the prolonged bed rest will give rise to constipation and incontinence of urine and stools, thereafter giving rise to poor appetite, swallowing problems, immobility, and you see there's no end to it. So we need to break this chain at multiple places. Maybe about constipation, maybe about the appetite, maybe about increasing mobility. In the UK, when patients do come in, they were given hospital pajamas, and they noted that by changing the patient's attire, that the patients became more delirious and confused. We may not give clothes for the patient when they come into hospital, but certainly the environment is changed. So the strategy where you say you don't have to take your clothes off, but you remain in your own clothes, we can do a change by making the best of it. Get the patient more oriented to the environment. So delirium is a common problem. It results in increased mortality, morbidity, but it is a preventable, it is a reversible condition. CAM is a useful diagnostic tool that can be used, and one needs to be aware of identifying predisposing factors and precipitating factors. Non-pharmacological methods should be used as first line, and psychiatric drugs, neuroleptics should be used for severe agitation when non-pharmacological methods are in fail. We need to remember about the patient and address the concerns of the patient. So I end with this, the song by Dr. McLean says, talks about Van Gogh, who committed suicide after a long spell of depression, which was not properly managed, maybe because of exigencies in the knowledge of psychiatry during that time. But it's essential what the person who composed the song says. Now I think I know what you tried to say to me, how you suffered for your sanity. They would not listen. We are not listening still. Perhaps we will never will. Thank you.
Thank you, Shayan, for that very comprehensive lecture. And again, it's a delirium is a very common encounter in clinical practice for all the physicians working in the wards. Then the last lecture, I would like to invite Dr. Kishara Gunaratne. He's a consultant neurologist and senior lecturer in Montreal University. And he will be talking to us on dyskinetic problems in psychiatric and cognitive disease. Over to you, Kishara.
Yeah, thank you very much for that kind introduction. Can you all hear me?
Yes, we can.
Yeah. Okay. Thank you. All right. So. Right. So I'll be talking to you on dyskinetic problems in psychiatry and cognitive disease. And at the outset, I'd like to thank both the CCP and the SLAGM for giving me this opportunity to speak to you on this particular topic. So let me proceed. Right. So dementias associated with movement disorders are the second most common form of dementia in old age after Alzheimer's disease, which is the #1 cause for dementia worldwide. And dementia in many movement disorders that are basically frequently associated with considerable neuropsychiatric comorbidity, right? And all of you must be aware of this particular slide. So movement disorders are generally sort of classified into hypokinetic movement disorders and hyperkinetic disorders. And then sometimes there is a combination of both hypo and hyperkinetic of the combination of both hypo and hyperkinetic phenomenology. That's what we call describe the movements. The nomenclature that we generally use is phenomenology, right? So if there's less movements or reduced or paucity of movements, we would generally class that particular movement disorder as a hypokinetic movement disorder, whereas if there's excess of movements, obviously it will be a hyperkinetic disorder, right? So these are the types of movement disorders that probably you all are aware of. Ranging from Parkinsonism, which is generally considered a hypokinetic movement disorder, going through chorea, tremor, dyskinesia, dystonia, and myoclonus are all examples for hyperkinetic movement disorders. Of course, on the right there are the examples of disease entities with the predominant movement disorder on the left, right? So that's what I thought is I mean, 20 minutes is a very short period of time for me to kind of cover the entire sort of spectrum of movement disorders that we would encounter, especially in patients who have cognitive disorders or psychiatric disorders. So let's start with a few cases which and then I can I would then highlight the few clinical points that are important in assessing these patients. So the first case is a 65-year-old male patient who presents with deficits in attention, executive and visuospatial function for the last 6 months. Variations in cognitive functions throughout the day have been apparent on detailed questioning from his family. He complains of tremor at rest and slowing down for the last 2 years. What is the diagnosis? There is a polling option. You can always poll. I'm going to play the video that the patient came with. This is the video. I hope everybody can appreciate that. Okay, so you can poll in your answers now. Let's open the polling. Okay, I think that's adequate time. I hope people voted. All right. Okay. Right. Okay, I think 75% of you have actually got it right. This is Parkinson's disease, dementia. Right. Okay. So see, this is what you see on the video is tremor at rest. Tremor that is worse when the patient is ambulatory, and it's basically very asymmetric and found on the right side, which is where all features of a tremor which a patient with idiopathic Parkinson's would have, and the attention and deficits in attention, executive function, and visuospatial function are very typical, cognitive domains that are generally affected in Parkinson's disease dementia. Yeah, absolutely right. Okay, so we'll talk a little bit about dementia. Lewy body dementia again is a combination. It consists of both dementia with Lewy bodies and Parkinson's disease dementia. And these two diseases are not discrete diseases. We think that these are different. They represent different points along of the same continuum or of disease with similar pathology and genetic overlap. So how do we differentiate the two? It depends on which comes first. For example, if the dementia comes on first, then we are thinking that this is more likely going to be dementia with Lewy body. Whereas if the dementia comes after the motor symptoms and signs, then then it's more likely that we are dealing with a Parkinson's disease dementia. And we have this rule in the 1-year rule, right? So that's for example, if the Parkinson's disease dementia, in Parkinson's disease dementia, the motor symptoms precede the onset of dementia by at least 1 year, then, in those instances, we would generally diagnose Parkinson's disease dementia compared to that of Lewy body dementia with Lewy body. is it important for so yeah, so around 85% of patients with dementia with Lewy bodies experience motor difficulties, but what you need to understand is that the tremor at rest is not as prevalent as in the patients with Parkinson's disease dementia, right? And that's a very important sort of clinical feature that we need to sort of use, which we can use to differentiate the two. In contrast to with regards to Parkinson's disease, it's often the dementia component is a late, in most cases, and not in all, but is a late manifestation of Parkinson's disease, where the disease has progressed to a sort of stage where there are fluctuations in motor phenomenon, and basically there's wearing off. There may be peak dose dyskinesias, and on top of that, the patient may have Parkinson's dementia. So that needs to be taken into consideration. And how do you treat the motor symptoms? In both entities, treatment of choice is levodopa. However, the motor symptoms improve. The improvement is marked in patients with Parkinson's disease dementia compared to that of dementia with Lewy bodies, where the response rate would be between 30 to 50%. And what you need to be aware of is that approximately 1 in 3 patients with dementia with Lewy bodies treated with levodopa will experience psychotic symptoms. So therefore, you need to have that at the back of your mind. Sorry for the busy slide, but what this slide is trying to basically sort of emphasizes the fact that you need to, if a patient, so the treatment strategies for both for treatment of motor symptoms in Parkinson's disease dementia and dementia with Lewy bodies is a bit different, and that's why it's important for you to differentiate the two. Is when so when you're dealing with a patient with Parkinson's disease dementia, it's always important to reduce the drugs which the patient is on, which can have profound effects on cognition. For example, anticholinergic drugs, which can have a profound effect on cognition, needs to be sort of taken off. And so you have this sort of sequence of drugs that we would generally take off when a patient is on has been diagnosed with Parkinson's dementia. And then, for example, you start with an anticholinergic drug, then going down to amantadine, salicylic, dopamine agonist, and last of all, catechol or COMT inhibitors like yeah. So basically, those are the sequence of drugs that we generally try to sort of stop. That is because of its cognitive side effects. With regards to treating patients with dementia with Lewy bodies, levodopa monotherapy is the #1 option for treating motor symptoms. However, the dose that is required is much less than you would use for patients with Parkinson's disease dementia. And that is because of the fact that the levodopa itself can precipitate psychosis. Zonisamide, not so much available in this country, can be a adjunct treatment for patients with dementia with Lewy bodies. Again, a very busy slide, but what I want to sort of emphasize is the fact that the anticholinesterase inhibitors such as donepezil and rivastigmine have evidence that for treatment in treating these patients, and that those are the two medications that have the highest evidence. These are the treatment options of choice when we treat these patients. So we'll move on to the next case. This is a 70-year-old male male patient with no significant past medical history, who presents with a two-year history of progressive changes in behavior. rush speech, verbal aggression, and social withdrawal. MRI brain imaging of the brain, MRI imaging of the brain revealed atrophic changes maximally in the frontal and temporal lobes. He is stiff and slow and falls backwards. What's your diagnosis? This is the video. Right, so what's your diagnosis? Is it vascular Parkinson's, frontotemporal dementia with Richardson syndrome? Is it PSP or Parkinson's dementia? So you can start voting. Okay, let's see what you have voted for. Yeah, so most of you all have actually got it right. So frontotemporal dementia with Richardson syndrome is the correct answer. As you can see on the video, is you can see a furrowed brow, which is very typical of Richardson syndrome or progressive supranuclear palsy. And you also, if you appreciated the vertical saccades, they're markedly slow compared to the horizontal saccades. So considering the history of mainly frontal and cognitive domains being affected, and the imaging to support your diagnosis, we come to diagnosis of frontotemporal dementia with Richardson syndrome. So there are a number of movement disorders that are associated with frontotemporal dementia. Most patients with frontotemporal dementia present in the 5th or 6th decade of life, often with a combination of progressive behavioral changes, executive dysfunction, and language impairment. There are two main clinical entities. One is where the behavioral component is disproportionate. We would generally name them as behavioral variants of frontotemporal dementia. And then we have the language deficits, which are more prominent than we would generally call, sort of name those patients as having primary progressive aphasias. The primary progressive aphasias are classified into semantic, non-fluent, and logopenic variants. That is again dependent on whether they have mainly receptive dysfunction or expressive dysfunction or a combination of both. The movement disorders that are generally associated with frontotemporal dementia include Parkinsonism, atypical Parkinson's, such as rigid akinetic syndrome, corticobasal syndrome, or Richardson syndrome, or a Richardson syndrome-like phenotype. So what the case that was sort of highlighted in this particular scenario was of that of a Richardson syndrome, or a Richardson syndrome-like phenotype. Okay, so the movement disorders that are associated with FTD, when it comes to Parkinson's, it's different to the normal idiopathic Parkinson's disease that we generally encounter. There, the muscle rigidity in these patients are generally symmetrical, as opposed to idiopathic Parkinson's, which is markedly asymmetrical. They have bradykinesia and they have Parkinsonian gait with generalized hypokinesia. They won't have the typical distinct tremor that we generally see as in the first case that was presented to you. Most patients do not respond to levodopa or may have a transient response. They may also present with a pyramidal syndrome with seizures and ataxia and dysautonomic manifestations that resemble what we call alpha-synucleinopathy, such as multiple system atrophy, or they may represent clinical features too that are sort of similar to multi-system atrophy or MSA. The typical progressive supranuclear palsy or Richardson syndrome again, similar clinical features as in the case where you would have a supranuclear vertical gaze palsy, axial rigidity, postural instability, early falls. Often they fall backwards. They often have dysarthria and considerable dysphagia, which are all axial symptoms and signs. They do not respond to levodopa. Then we have the Richardson Syndrome-like phenotype, where you don't have all the features of the Richardson Syndrome. They may have features of akinetic, rigid akinetic Parkinsonism, where they do not respond to levodopa, and may have a few features of supranuclear palsy, and the commonest is that of a supranuclear gaze palsy. Corticobasal syndrome, they will have asymmetric rigidity, apraxia, cortical. So generally we see it often a unilateral manifestation where you see the dystonic posturing. They might have myoclonus associated with that particular limb. They may have cortical sensory loss and what's called an alien's limb syndrome or phenomenon that affects that part of the body. If the affected hemisphere is that of the left hemisphere, which is often the dominant hemisphere, they may also present with a primary progressive aphasia as well. Often frontotemporal dementias are associated with defects or genetic defects, and often it involves chromosome 17 as well as chromosome 9. And by analyzing the phenotype, say for example, if the patients with frontotemporal dementia have a rigid akinetic syndrome, these are the mutations that we generally look for in APT, progranulin mutation, as well as C9orf72. These are the three main mutations that are common. Then, of course, if they come with a Richardson syndrome, or Richardson-like syndrome, then we need to look out for the MAPT mutation, which is found on chromosome 17. And also corticobasal syndrome, we would then go for the PGRN or progranulin mutation, which is again found on chromosome 17. There's also the association of frontotemporal dementia with motor neuron disease. And the commonest mutation is C9orf72, which is seen worldwide. So these three are the three most common phenotypes and the corresponding mutations that we generally encounter in clinical practice. Right, so then we go on to the third case, I think, yes. A 66-year-old woman had a five-month history of rapidly progressive cognitive decline. She had problems with short-term memory and functional abilities, including getting dressed, using the toilet, getting lost in her house. Her husband also stated that she had emotional lability and at times did not trust her own family. Her vision was becoming blurry and she had increasing somnolence. On examination, she had myoclonic jerks, which are stimulus sensitive, tremor, and gait ataxia. What is your diagnosis? You can start start the poll right now. Okay, let's see what. Yeah, okay, I think nearly 81% of you all have actually got it right. So this is a typical history for Creutzfeldt-Jakob disease or sporadic CJD, and which is an example for a rapidly progressive dementia where there is cognitive and neurological decline or progressive changes over a period of weeks to months as opposed to months to years, which is generally seen with all the other dementias. And it can mimic certain treatable and reversible causes. And one example is autoimmune encephalitis. So there's a wide spectrum of how CJD can present, and you need to be aware of that. What is presented in the history is that of the classical CJD, where there is global cognitive decline, cerebellar ataxia, myoclonus, and motor signs. And the initial presentation would be of these classical sort of clinical features, which will then progress to an akinetic and mute sort of syndrome. There are other presentations. For example, they may have just pure cognitive presentation where they would have executive dysfunction, expressive dysphasia, parietal lobe signs, and apraxia, which then progress to an akinetic mute sort of syndrome. Or they may have just the ataxic variant where they just have ataxia, may or may not have myoclonus associated with that. They may have purely neuropsychiatric problems where they have depression, aggression, delusions, and hallucinations, which can then progress to akinetic mutism. They may have visual variants, which is called the Hayden-Hine variant, where they have cortical blindness, and they may have what's called a Balint syndrome, which are all features of the posterior cortical structures being involved, which then progresses again to a kinetic mute sort of syndrome. They may have problems with sleep, where they have, because of the thalamic involvement, with peripheral pain and sensory disturbance, again progressing to a kinetic mutism, and stroke-like syndrome is not very common, but can be a presentation. And of course, the corticobasal syndrome of dystonia myoclonus, which is unilateral with an alien limb syndrome, again can proceed into an akinetic mute sort of syndrome. So these are the spectrum of CJD and the clinical presentation of CJD is quite varied, but the classical is the one that you see on the right and has been highlighted in the case report. Case that has been presented. How to confirm CJD? Often the MRI or imaging is very useful, where we see the classical abnormalities involving the striatum and the cerebral cortex, as well as the thalamus. The EEG may show a periodic sort of sharp and wave discharges at a 1 Hertz sort of periodicity. But this is often seen fairly late in the disease. CSF tests can be sort of useful, where there is, because of the disease itself, there can be destruction of proteins within the central nervous system, which can release these proteins, which include protein 14-3-3, S100B, and neuron-specific enolase, which is detected in the CSF. And approximately 80% of these patients with CJD will have these proteins within the CSF. Just to show you, illustrate the imaging findings, where you generally see the striatum light up, this is called the hockey stick sign. Then also you will see cortical ribbon, where you see these hyperintensities involved in the cortex, often appreciated on diffusion weighted imaging. And then, of course, we have the thalamic hyperintensities, or the pulvina sign, which is not very common with sporadic CJD, but very common with the variant or the new variant of CJD. Again, the EEG, where you see these periodic discharges that is highlighted on this pic, and often occurring at a 1 Hertz periodicity. These are the so there are diagnostic criteria that have been laid down, and if you have 2 of these clinical features, which include myoclonus, visual or cerebellar problems, pyramidal or extrapyramidal features, or akinetic mutism, plus one of the investigations that have been highlighted, either imaging or positive CSF or an EEG to support the diagnosis, you may be dealing with Creutzfeldt-Jakob disease. Right, we'll come to the last case. This is a 70-year-old patient who, on treatment for diabetes and hypertension, came with these movements. She's on risperidone for the last 2 years. What is your diagnosis? Okay, you can start voting now. Okay, so let's see what you guys have to say. Yeah, so this is typical for tardive dyskinesia. So let's move on. Right, so most of you have actually got it right. So tardive syndromes are seen often with patients receiving neuroleptic drugs. And why is it important in the elderly? And that is because it's actually more prominent or more prominently seen, or the incidence is much higher in the elderly population. And as you can see in the slide, the more older you are, and if you are on these drugs, then more likely that you will sort of experience the side effects of dopamine antagonism. So the risk of developing these tardive syndromes increase with the duration of exposure as well as the medication dose. And you can have a cumulative incidence of approximately 25% over after 5 years of exposure. Commonly seen with drugs that are that block the dopaminergic receptors, and often the pathophysiology involves increased dopamine turnover and formation of oxygen free radicals as a result of the monoamine oxidase enzymes, and these free radicals are toxic generally to the striatum, causing gliosis within the basal ganglia. There was this theory some time back where this was supposedly due to an upregulation of the dopamine receptors, and because of chronic blockage or blocking of the dopamine receptors. And because of the upregulation, the theory was that these dopamine receptors become hypersensitive to dopamine. But that is now fallen out of I mean, people don't, experts don't agree with that hypothesis anymore, and more in favor of this oxygen-free radical theory. And that is because the tardive syndromes, now if that was the case, if once the offending drug is stopped, should return back to normal. But in most cases, actually, the tardive syndromes do not come back to normal. So there is a permanent sort of deficit in these particular patients. And examples for the drugs are basically typical antipsychotics compared to the atypical antipsychotics. The chances of tardive syndromes are higher. Metoclopramide and lithium are all examples that of drugs that basically can cause this kind of syndrome. You need to ask yourself 3 questions. Basically, is there a history of, especially when you're diagnosing such tardive syndrome, is there a history of a dopamine receptor blocking agent that has been used? Is there a temporal relationship of symptoms to this particular drug? And does the clinical phenomenology compatible with the tardive syndrome? So what is the phenomenology of a tardive syndrome? These are basically stereotyped choreotype movements which are predominantly seen in the lower half of the face, which include the lips, tongue, and perioral region. As you saw in that particular video, the phenomenology, there are the particular physical signs that we see is the flycatcher tongue, where the tongue protrudes in and out, then the bonbon sign, where the tongue pushes out the cheek in and out, and also the piano player dyskinesia, which is where we see the dyskinesia involved in the distal parts of the fingers, which resemble a piano player. these tardive syndromes have added features such as tardive akathisia, where the patients have extreme difficulty in staying or keep sort of staying stationary, and they all have this internal sort of they have this need to move, which causes them quite a lot of distress. The tardive stereotypies are very similar to the tardive akathisia, but they don't have this in the internal notion that they need to move. Tardive dystonias, commonly seen in the craniocervical region, can manifest as opisthotonous tardive Tourette's, right? Tardive tremor, tardive myoclonus, and tardive gait, all clinical features that can be found in this particular syndrome. This is a video of a tardive akathisia. You can actually see this patient was asked to sit down. He was as you can see, he's fidgety, he's moving around in his chair. He doesn't really want to sit down. Yeah, and so he really couldn't stay still for that 5-minute interview. Okay, so there are several myths involved in tardive syndromes. So there's the myth of second-generation antipsychotics, that they have a reduced incidence of tardive syndromes. This is a myth. The prolonged exposure to a causative drug is necessary to be at risk of tardive syndromes. Again, a myth. I mean, even a short duration of the drug can cause these syndromes, and that some neuroleptics are safe. So all neuroleptics basically can cause tardive syndrome. Treatment is to stop the offending dopamine receptor blocking agent and use a less sort of potential drug which has less of a potential in causing tardive phenomena. An example would trazopine. Of course, you can use the VMAT2 inhibitors such as tetrabenazine, available in Sri Lanka, valbenazine, and deutetrabenazine, not so much available in Sri Lanka. Propranolol, clonazepam, useful drugs in treatment of the tardive syndromes. Botulinum and trihexyphenidyl, useful for tardive dystonias. So these are the treatment options that are available. And I think I've come to the end of the talk. So in conclusion, what I need to highlight is that some patients present with abnormal movements and later develop dementia, while others have dementia as a predominant initial clinical feature and then develop abnormal movements as the disease evolves. So that needs to be borne in mind, and analyzing the cognitive domains that are predominantly affected and the phenomenology of the movement will often give you a clue to the diagnosis. And drugs for psychiatric disorders can cause a spectrum of movement disorder, which can cause diagnostic confusion and is prevalent, especially in old adults. What I have not touched upon is late onset chorias, for example, Huntington's disease, which is again one of the movement disorders which can present as in the elderly with neuropsychiatric manifestations. And I've also not touched upon the autoimmune encephalitis, which is a completely different topic altogether. Okay, thank you very much for your kind attention.
Thank you, Kishara, for that very interactive and informative lecture. And now the Q&A session. We'll entertain only 2 questions as we have run short of time. This is probably for Shehan. Is haloperidol prophylactic for delirium?
There is no, sorry, let me get my video open. Sorry, there is no guidelines saying that there are any medication that can be used prophylactically. There are such studies that have been done to look at the possibility of prophylactic use of pharmacotherapy for delirium, but nothing is in the form of guidelines as class A, grade A evidence. And haloperidol is not, it should not be given prophylactically. As I mentioned, we have to be mindful of the side effects that the drugs can give rise. So we have to be very judicious about that. I see that there was another question about a drug called dexmedetomidine in Sri Lanka. So we don't have that drug. That drug was actually, I also came to know about that drug at the ACP conference this year. Professor Maldonado mentioned about it in his lecture. That too is still not in the guidelines, but there are certain centers that use it in the States, I presume. But we don't have this drug. It's not registered still in our country.
And there's another question, probably Dr. Kapila might answer. Is Levy body dementia a rare diagnosis? Your mic is muted.
Sorry.
Yeah.
Because I'm in the chat room.
Yeah. The question is Levy body dementia a rare diagnosis?
Yeah, I got the question. It is not rare actually. I mean, it's probably the same incidence and prevalence is there in Sri Lanka. Unfortunately, it's not diagnosed properly. I think that's my experience. I think we do diagnose Lewy body dementia and Parkinson's dementia both separately. It's the lack of expertism and proper assessment that leads to the, I mean, not seeing cases in Sri Lanka only. I, of course, have diagnosed many. So it's not that rare. The patient has to be assessed very carefully to fulfill the diagnostic criteria. So it is rare by the incidence all over the world, but it's not comparatively rare, particularly in Sri Lanka. It is there in Sri Lanka. I hope that will.
Yes.
I thought it's not seen in Sri Lanka. It is seen.
The next question is to Kishara. Kishara, the question is, what are the evidence to suggest that second-generation antipsychotics with low D2 blockage do not have a reduced potential to cause tardive dyskinesia?
Do not have a potential or do have a potential?
Do not have a reduced potential. Do not have a reduced potential.
They have a reduced potential. The incidence of tardive syndromes compared to the typical antipsychotics so with regards to typical antipsychotics, the prevalence is much higher. However, even with the atypical psychotics, we do we do see patients experience these tardive syndromes. So it's not rare, and that's one of the myths and fallacies that I highlighted in one of my slides.
Yeah, thank you, Kishara. So I think we have run short of time and we need to wind up this session. And on behalf of the Ceylon College of Physicians, I would like to thank all 4 speakers for their wonderful lectures. And I think it's very, very important for all the physicians who are working in the wards. And it's in a practical way. And also I would like to thank Professor Sarath Lekamasan, the President of the Sri Lanka Association of Geriatric Medicine, and also Shehan Silva, the Secretary of the Sri Lanka Association of Geriatric Medicine, and also the College of the is collaborating with the Sri Lanka College of Physicians, and we have concluded the month of geriatrics, which is November, and we had 3 events like the college lecture, the expert webinar, and also today we had the specialty update. And also there's another announcement that the CCP has declared the month of December as the month of hematology, and we are having a college lecture on 7th of December in hematology. And so before winding up, I would like to thank Shehan for coordinating all these events, and also the specialty update, and also Nalina and the audiovisual team for their continuous support. And we will be meeting up on 7th of December with the college lecture and the YPF in hematology. Thank you. Have a good day.
Thank you.